Thanks very much. I've had the opportunity to be here all day yesterday and this morning. The previous speakers did such a great job. They mess up my pattern. I sit in here and I pretend like I listen and I really answer my emails. I'm 3 hours emails behind, so you guys have done great. It's been awesome to listen to. So today what I thought we'd do is sort of give you some practical advice about sort of, surgeons always do the how I do it talk, and here's my video, and this is how I do it. We're going to show you a little bit of sort of about the practical applications. Clearly, we're doing sort of minimalistic, less is more sort of approach. And to no surprise, probably there's no pharma support for less is more, so there are no disclosures there. What we're going to look at is sort of looking at where we came from, how did we used to treat thyroid cancer, look sort of now at our modern approach. And really what I'm going to do is I'm going to take you through about risk, sort of the way we think about risk stratification for about 20 minutes. And then I brought about 8 cases. And we'll see how many of the 8 cases that we can get through. Work through sort of real world, what it looks like. These are 8 cases either I see in clinic every week or you guys email me about or somebody does. And I also want to sort of do the advanced part because the ATA thyroid guidelines, while they were really cool, published in 2015, written in 2014, that's a long time ago. And that's a lot of data ago. So I'm going to show you kind of how we've evolved from that. And I'm not on the new guidelines committee this year around. They made a rule that nobody should be on more than 2 cycles in a row, which I totally supported, which meant I got all my weekends and nearly a year back from not writing guidelines. But from what I've heard them presenting and teaching about, it's going to be 2015 just move forward a little bit as we would have expected and should be consistent with what I'm showing you today. Now, in the old days, treating thyroid cancer was easy. You only needed sort of 1 hour. You take the thyroid out, you give radioactive iodine, and everybody does great. But oncology has changed. Oncology has changed. If my mom or my sister or my dad had a lung cancer or breast cancer or colon cancer, I really wouldn't want a one-size-fits-all for mom or dad, right? There's things about mom. It depends on the age. It depends on the size. Maybe for my mother-in-law, but for mom or dad or... Okay, all right, you laugh. But when's the last time? You always get this in clinic, right? If I was your mother, would you? If I was your father. Has anybody ever heard, if I was your mother-in-law, what would you do? No. When you do, email me that and I'll put it in my talk. Not sure why. Recurrent guidelines. The guidelines, so are doing what we want to do, which is individualized management. Now, why did things change so much? Well, I think what changed so much was the landscape of thyroid cancer changed underneath our feet. In the first 10 years of my career, I specialized in treating really bad disease. Brain metastasis, bone metastasis, aggressive disease, because that was what was coming to see us. And what are we seeing now? Think about the last 10 thyroid cancer patients you saw. What do they look like? They had an ultrasound found a nodule. A CT scan found a nodule. They're 8 millimeters. They're 9 millimeters. When's the last time we saw somebody walk in the door with a palpable lymph node metastasis or choking or hoarseness, right? The disease that we're seeing has changed under our feet. And in fact, this big rise in thyroid cancer that we saw was really driven by lots of small thyroid cancers, 1.5 centimeters. And so we had to ask, did those paradigms that I learned in the 1990s to treat aggressive disease apply to the patients that I was seeing today? Today, the vast number of my consults are not high-risk cases anymore. They're papillary small cancers. They're intermediate cases. Do I use radioactive iodine, yes or no? Often, I don't want to use radioactive iodine, but will you see them one time and make sure this is okay not to do that, right? It's a whole different spectrum of disease that we were seeing. And so it's no surprise that the guidelines committee recognized that in the midst of this and began to draw back first on the use of radioactive iodine because these are small thyroid cancers that surgery alone is curing. And then you had to take the next step and said, well, if we're not giving radioactive iodine to everybody, do we really need to do a total thyroidectomy? Right? Because when everybody was getting radioactive iodine, that was really not a discussion from 1975 till 2015. But if you're not going to give radioactive iodine, or it's a possibility, why do we do total thyroidectomies? Would a lobectomy be appropriate? And then you take the next step that says, well, we're finding such small disease. If you find a 4 millimeter papillary thyroid cancer in my dad who's 85, have you done him a favor? Have you helped him with a surgery? Have you damaged him? You made him a cancer patient. And we say, don't worry, it's a small cancer. But when's the last time the patient looked at you and said, oh, cool, whew, glad that's a small cancer? No, you don't get that, right? Yeah, I know. It's a big deal. So when we think about the spectrum of thyroid cancer, trying to get the right approach and the right management really evolves not just in this initial therapy space, which is, do we do surgery, do we do radioactive iodine, what's the TSH suppression, but it starts all the way back here in the patient's journey, where that suspicious nodule is identified. That's before the biopsy. Begin thinking about, is this good to do? And the new guidelines, I think, are going to dwell more on our long-term follow-up. Because just like we have to minimize the upfront treatments, these patients don't need 25 years worth of follow-up with an endocrinologist for a papillary thyroid cancer that was treated and cured. What does that long-term follow-up look like? And do we have to do 8,000 ultrasounds? And do you have to do thyroglobulin antibodies? And if the risk of recurrence is 1% and you have an antibody, do you want to spend $1 million chasing down that antibody when in fact the likelihood of having disease is 1%, right? So that's how you get guidelines that begin to challenge, not a question about whether the techniques of the assay, not a question about whether could you measure the antibody, but in that clinical context, what's the likelihood if you don't see anything and somebody's 5 years down the road and you get a TG positive antibody, what's the likelihood that's going to lead to clinically detectable disease? Different question, right? And so it moves us into those sort of uncomfortable areas of writing guidelines that say maybe we don't have to do all that. And now you're in this sort of trying to find the right pendulum, trying to find what's the optimal management. And Jerry Doherty a few years ago gave a lecture. Jerry said his goal was to do just enough. And that really resonated with me. So if you send me your patient with thyroid cancer, my goal is not to do everything unless it's not necessary. But the goal is to do just enough. What's just enough to give you great outcomes? What's just enough to minimize the side effects of anything I'm doing? And that includes from diagnosis to treatment to long-term follow-up. So if you're uncomfortable with just enough, this is going to be a long 50 minutes. Here we go. So this is where I got started in risk stratification. Started my fellowship in 1990 with a young endocrinologist you may happen to know named Dr. Mazzaferri. Ernie was my initial mentor, and then I had to learn the pleasure of learning from Lynn Ortofsky and Ken Berman. So I came from a pretty aggressive management stock, right? So I often say, hi, my name is Mike, I was an overtreater. That's how I start this. If you want to know about the complications of radioactive iodine, I know what they are. I did that. So if there's a way on PubMed to erase anything I wrote before about 2005, that would be a good idea. Risk stratification in 1990 focused on that initial thing, focused on really the risk of dying. And in fact, it's so unusual to see a patient die of thyroid cancer. I don't know why we were fixated on risk of dying in a 40-year-old with papillary cancer. It was a single point estimate. It never changed over time. You were called high risk and you stayed there forever. And at least for me, it didn't predict the risk of recurrence. And as a fellow, I really wasn't worried about most of these patients dying of thyroid cancer. It was the risk of persistent disease or recurrence. And we needed a better way to be able to think about that. So now if I look at where we are in sort of 2024, risk stratification begins all the way back from the minute we find a thyroid nodule. Doesn't begin at the time of surgery. From the minute somebody finds out, and honestly, this is risk stratification often before they get to us, right? This is in the primary care arena. This is in the OBGYN arena. This is the emergency room that orders these scans. And we have to get to them and say, look, there are things in there that we may not have to do anything about. And if you find a small suspicious thyroid nodule, do you have to really do a fine needle aspiration? You saw this in the guidelines. For many years, we said if it's less than 1 centimeter, even if it's suspicious, you don't have to do a biopsy. And previously, it was less than 5 millimeters, right? What did that mean? That meant we didn't think you need to diagnose cancer. Now, thank God nobody thought about it that way. Otherwise, you'd have thrown the guidelines away. But if you're saying you don't have to biopsy something less than 5 millimeters or less than 1 centimeter, even if it's suspicious, what are you saying? You're saying not a good idea to diagnose a cancer. Different way to think about it, but that's really what that sentence means. And even if you diagnose a cancer, do you have to do immediate surgery? We get this all the time, right? You know, somebody says, well, I know I need surgery, but I'm getting married in 3 months. Can I wait 3 months? And you guys all say, yes, help me out here, stay awake. Yes, okay, cool. And then I live in New York and I work in Manhattan. And so her parents were going to send her on a vacation for their honeymoon for 6 months. Can she wait for 6 months? Yeah, 9 months, what the heck, cool, awesome. And then she comes back and she's got a new job with Jamie Dimon on Wall Street and doesn't really want to take off. Can she have another 6 months? And you said? Okay, cool. So now you're 18 months down the road and she comes back and she goes, hey, do we need to do surgery at all? This thing hasn't changed in 18 months. And what do you say? Yeah, go get a consult at the Mayo Clinic. That's what I would say. Total thyroidectomy or lobectomy? Which one should we do? And are you really? What we're asking is, are you a candidate for minimalistic management? That's the real question I ask when we see somebody with a small thyroid nodule, suspicious thyroid nodule. Are you a candidate for minimalistic management? We stole this peri-diagnostic wording from the pulmonary literature. Pulmonary guys, when they have all these little small pulmonary nodules, they refer to this as peri-diagnostic risk stratification. Because sometimes the pulmonary guys will say, don't do anything, do another one in 6 months, right? Or I biopsy that one, or I do something. They are consciously making the decision about whether they need to make a diagnosis. Yeah, I know biopsying the lungs is a little harder than the thyroid, but intellectually it's the same process. Are you appropriate, ideal, or inappropriate for watching? Well, as we sort of thought through that, we realized when we were trying to figure out if you were a good candidate for minimalistic management, we were really looking at 3 characteristics. What were the ultrasound or imaging characteristics? If it's growing into the windpipe, if you got a ton of lymph nodes, we're not going to watch that, right? What are the medical team characteristics? Because remember, this is applied all over the world. ATA guidelines aren't just for Americans. They're applied all over the world. What if you're in a situation where you can't get levothyroxine? Is that going to color whether you do a lobectomy or total thyroidectomy? Somebody maybe you would normally do a total thyroidectomy on, but they are not going to be able to get levothyroxine for the next 20 years. Would you be better off with a lobectomy and not having a TSH of 100 following a total thyroidectomy, right? That's the medical team characteristics. And then often people will take this slide and say, well, if you're in a really ivory tower, really good place, then maybe you can watch small thyroid cancers. But if you're not, you should just go ahead and do the thyroidectomy. I'd say it's the opposite. That if you're in a place that doesn't have good imaging, you're likely in a place that doesn't have really experienced surgeons. And the complications of surgery and follow-up may be more than the cancer, right? Thinking about this sort of in the real, whole world kind of setting. We can also take the next step in this and say, look, yeah, if you're not a good candidate for watching or active surveillance, maybe you're a good candidate for a lobectomy. Now, the real truth to the patients is I'm not going to know whether they're a good candidate for lobectomy until a couple weeks after surgery. I'm going to guess based on tumor and ultrasound and patient characteristics, and we're going to say, yeah, we think you're a good candidate for a lobectomy. But at Memorial, we routinely have patients, if they will, sign for lobectomy or total thyroidectomy and leave that discretion up to the surgeon. When she gets in there, if she finds lymph nodes behind the thyroid or unexpectedly stuck to the thyroid, we want them to be able to go ahead and do the right surgery, because if we'd have known that information before surgery, we would have made that information. But then also patients have to understand there can be some things on the path report. If you give Tarek more than 10 minutes on a microscope, there's a good chance he's going to find something that's going to take me 20 minutes to explain to a patient. There's a direct correlation there. Every line you add is another 5 minutes to my consult. No pressure. But all of that, right, they're going to have to know. I may look at that and say, at Memorial, when that usually happens, it's vascular invasion. Can't see it on the ultrasound. Surgeons don't see it. Looks nice and encapsulated, no big deal. And the path report comes back with 6 foci of vascular invasion, taking you up into that higher risk category, right? And so there are some patients that are not comfortable with that indecision. Look, you're going to put me to sleep one time, doc, that's it. I'm going to pick a really good surgeon and be done. And other ones say, no, I understand that. If most of the time the lobectomy will be the right answer, I'll take that. But as they think through the process with you, they have to know that. Now, we'll move on and then say, okay, we're going to do risk stratification at the time of surgery and the initial treatment. And we'll use the traditional thing, the 8th edition of the AJC staging system, the ATA recurrence. You're going to see both of these modified a little bit. The 9th edition we're just starting to work on, and there are going to be some subtle changes we're going to make in the 9th edition. If I have my way, just invasion into strap muscles alone, we're going to downgrade that because those patients do really well. And a lymph node invading a nerve, probably downgrade that a little bit. If it's a small papillary invading a nerve because it happens to sit behind the thyroid, all those are instances where they kind of got upgraded a little bit too much, so we'll see. In the HA risk stratification, they're going to take from a 3 classification to a 4. I think that's perfectly fine because we've all done low, intermediate, and high, right? And then in that intermediate group, people would say, well, there are some people that live on the low end of the intermediate, some people that live on the high end of the intermediate. And so I think the new guidelines are going to break those out, which is good because that's what we've been doing. So you'll probably see a 4-tiered system. From a practical application standpoint, I think the real key here is that initial risk stratification based on AJCC or based on ATA, you can use all the information you have the first 4 months after surgery. We put this in the AJCC 8th edition because I wanted folks to have time to do some initial assessment after surgery. Now, think about all the data you get the first 4 months after surgery. You get a post-op thyroid globulin at 6 weeks. If you're doing radioactive iodine scanning or therapy, you know that information at that point. If you need an ultrasound after surgery, all that stuff to sort of clarify that appropriate initial risk stratification. Anything within the first 4 months should go into that. And then at the end of the first 4 months, that's where they are. We've got 7 grandchildren, and they're all born a certain height and a certain weight, and they don't change. Some of them I like, some of them I don't like. You can't tell when they're born. You like them all when they're born, that's fine. But then as things change over time. So their AJC stage and their ATA risk is their height and weight. That will carry through their entire thing. So that's their pretest probability of having bad things happen. Because even if you're ATA high risk and you have an excellent response, you still got a little chance of recurrence that may be there. If you're a stage 3 and an excellent response, still got to worry a little bit more, right? This is pretest probability issues. And then what happens is thus far we've negotiated the first 4 months after their therapy. And then over time we sort of want to look and say, how do things change over time? It was this idea of dynamic risk stratification that several people came up with at the same time, kind of 2005. Furio Piccini in Italy and I were doing it, just like parallel, thinking through this the same way, with the idea that, yeah, we know how you're born, but one of my grandkids is a baseball player, and another one plays piano, and another one's a cheerleader, and I couldn't have picked out which was doing which on day one, right? Things are going to evolve over time, and we needed a way to be able to say we recognize things evolve over time, so let's come up with some wording to describe the first time I see you, the picture's a little bit fuzzy, and then every time you come back, the picture gets a little bit more clear, right? As we have more data. We use words in clinic like, you're doing better than I expected, or you're doing great, or you're doing awesome, or I'm a little worried about that number. I'm a little worried about that ultrasound, right? Those are phrasing. We're changing their risk stratifications, but in a nice way. And so we just wanted a way to be able to come up with 4 different words. I do nothing if not name stuff. And we needed to be able to describe what was their status every time they came back. And so we invented these words. Excellent response, because at that time, remember this was 10 or 15 years ago, in thyroid we were still forbidden to use oncology terms. You couldn't really say remission. So this is our secret remission, right? Because if I said remission, nobody would have used that word. We do now. But excellent response, no evidence of disease. Biochemical incomplete response, those daggone low-level TGs and antibodies that there's no structural disease. Many of those are fine, but you got to keep an eye on them. And then that indeterminate. The indeterminate is where we put, if you follow back to Jessica's talk, those thyroid globulin values that vary between 0.1, 0.2, and 0.3, we did not call those biochemical incompletes. We call those indeterminates. And part of the indeterminates was understanding that fluctuation in numbers as these TG assays got better. We chose less than 1 to be indeterminate because almost all the data was off the first generation assays with a cutoff of 0.9. So that's where the 1 came from. And so when you switch to these assays, and we did the same thing, we switched from a 0.9 assay to a 0.1 assay about 7 or 8 years ago. Dude, it was a long year in clinic to explain why things got better. And sometimes the numbers got higher, sometimes they got lower. They went from undetectable to detectable. And if I have to have one more 30-minute visit because somebody's thyroid globulin number doubled from 0.1 to 0.2, I'm going to lose my mind. But I try to put a smile on my face and look out the window and be nice. So what happened in these tumors? So when we did this stratification system, this was validated across the entire world, multiple different centers, ivory towers, all different parts. And invariably, as you'd expect, it's the natural history of the disease. And if they had an excellent response, their risk of recurrence really hovers around 1 or 2%. If you keep doing ultrasounds in these low and intermediate risk patients that had an excellent response, the false positive rate on your ultrasound runs between 35 and 45%. So you probably shouldn't put in your note, I'm planning on using a test that has a 35% false positive rate to detect a 1% chance of recurrence, if you want your institution to sort of value what you're doing, right? But that's the reality of what we're doing. And you're going to see in the new ATA guidelines, they're starting to back off in selected patients these follow-ups. Same way with the biochemical incompletes. A lot of these thyroglobulin numbers drop down over time after just surgery up front, sometimes after surgery and radioactive iodine, so following them. The group that we have to really focus on is the structural incompletes. We got rid of recurrence, we got rid of persistent disease, and just said, at the time I'm seeing you, it's structural disease, and how do we deal with that? And if you look at the deaths in thyroid cancer, this is where they come from. Structural incompletes, almost always with distant metastasis. Outside of that, you hardly ever see anybody die of thyroid cancer. Now, one of the issues then became is as our technology got better, and as the ultrasound got better, that heart attack you heard me have over there was when Jessica showed that maybe we could measure thyroid globulin, was it 0.05? Under the please God don't category. I can't cure anybody right now with a TG of 0.1. So, as our technology gets better, we're going to find stuff that we have to call detectable but not actionable. Now, we use the word detectable findings. You don't have to prove it's thyroid cancer. You just have to say, well, there's a little change on the ultrasound, there's a little change on the CT scan. Even if it was thyroid cancer, I wouldn't have to do anything about it right now. So we'll call that a detectable finding. No judgment. Might be, might not be, but doesn't need to be anything done right now. And when you look at my bias, the vast majority of what I find is detectable but not actionable. I joke about it all the time, but we feel this in clinic, right? Small things, the way ultrasounds are read, the way CT scans are read, that sort of stuff. And so we developed a pilot's checklist that said, well, what are the 5 things if I'm going to watch a bunch of little stuff? What are the things that are going to make me stop watching? We stole this from the airline industry because part of the reason flights are safe is because pilots go through a checklist every time. I have a sheet of paper this, and when I know I'm going to be talking about a patient with this, I bring it into the room and I say, these are the things that we think about. What's the size of the tumor? You can't watch a baseball in the neck. There's not enough room up in there. It'll grow into stuff. How quickly is it changing? Is it changing every 10 years? Is it changing every 6 months? That's going to drive you to do something. What's the location? Sometimes small things in bad locations have to be taken care of. Small things right beside a spine or a brain or a recurrent laryngeal nerve or the trachea, right? So that location has to count. Either symptoms or likely developing symptoms would do it. And then the last one is the patient preference. I don't put that last because they get the last vote. I put that they need the first 4 things first. And then the patient to understand with me, what's the benefit of doing something? What's the risk of doing something? What do you value? I tend to see a lot of people that are professional voice users, and their number one value is their voice. And if you're doing something to their neck that's not saving their life and is not going to prevent something bad from happening in the next year, they want you to watch. Some people want you to watch to a better time. They use my watching program as a bridge to a better time. A couple of New York policemen that are going to retire in a year or two, and other professional voice singers are going to retire. They're going to do their last movie. Yeah, can I watch this for a while? And I think that all falls under the patient preference. So if you look at sort of how we do clinic today, we start from that early watching, from the minute we find the tumor and begin to ask, what are you a good candidate for minimalistic management, right? That's my just enough philosophy. What's the just enough I can give you long outcomes? If we need to do something, that's fine. And remember, you see a couple of circles up here at the top. These circles that are up here at the top. That means we can change our mind. You can't change their birth and their height. That's the way they're born. But if you think somebody's good for minimalistic management to watch, that's fine. A few of those will change. A few of those papillary microcarcinomas will grow. A few of those lymph nodes will grow. And you just change your mind and say, you're not really acceptable with this anymore. Here's the 5 checklists. This is why we're going to do something. And the same thing when we're out here on this end. You had an excellent response. We're going to back off and see you every year or two. But if the thyroglobulin starts to change or the antibody starts to change, or maybe you're high enough risk you need a screening ultrasound at 5 years, we may change your assessment right now and change our follow-up. You with me? So from day one, that's where we are. So let's do a few cases and see what happens here. Okay, so I used to refer to this as middle age. I don't anymore. This is now clearly young. 54, gets a carotid ultrasound, accidentally finds a thyroid nodule. The outside doctor finds a 5 millimeter papillary thyroid cancer, and they come to you to see what to do. So what do you recommend? Here we go. You get to choose active surveillance, lobectomy, total thyroidectomy, total prophylactic, or thermal ablation. Active surveillance, quickly. Perfect, good. And thyroid lobectomy. Liar, pants on fire. Total thyroidectomy. Nothing? Yeah, okay, cool. Total neck dissection. Thermal ablation. Not a reasonable bad thing. So you guys would all just watch this? So you're going to, with a straight face, you're going to go, yeah, I think you have cancer and I don't want to do anything about it? Do you want to vote again? Or you just voted because you knew that was the right answer? Cool. Yeah, if I was Steve Sherman, you guys would be like, I'd take that out. I'd get rid of that. No, that's exactly right. So the key is you're in that peri-diagnostic thing, right? Now, ideally, I would have loved to have you made the decision about whether or not a biopsy was even necessary. At 54, maybe it was, maybe it wasn't, but you should have that discussion, right? Because she's now a cancer patient, and all of her notes say cancer patient. If you wouldn't have biopsied it, she'd be a patient with a suspicious thyroid nodule with no impact on insurance and no impact on a little different thing. So you have to have that discussion. And when you do, when you look at it, it would depend on all the other characteristics. What if I told you that I saw her last week and she's losing her insurance in 3 months with no ability to come back and see me? Still watch? Do surgery? You have to think about it, right? Now, I would watch because I think this should be watched, and she'll probably get insurance over the next 5 or 10 years, but it'll be a different discussion, right? So all of those individual things. What if she told you that the most important thing to me is keeping my thyroid? That makes it easy, right? My sister had surgery and gained 100 pounds. Dr. Google said do surgery tomorrow, right? All of that is in that patient factors that we do. And in fact, if you look at these patients at Memorial, about half choose to watch and about half choose surgery. And I have the most aggressive observation surgeons on the planet. They are totally with me on this, and they send me people that they know can't watch but want to have that discussion, so we send them back. What about this? So 23-year-old, this one's a professional model. The real case, her job was to look beautiful at a radiology convention, but they wanted to practice doing ultrasounds, and she agreed to it. It seemed like a good idea. 1.3 centimeter thyroid nodule, no other abnormalities. FNA confirms papillary cancer, and her plan is to get pregnant this year. So here's your same options. These are going to be the same options. But I took you from a 5 millimeter in a middle-aged person. We make her 23 years old now. We make the nodule a little bit bigger at 1.3 centimeters, and she wants to get pregnant. Now, what's the vote? How many would say active surveillance? Well, boy, you guys are black and white, aren't you? That's good. Lobectomy? How many say lobectomy? Okay, cool. How many say total thyroidectomy? Cool. All right, moving in the right direction. And thermal ablation, probably a little big. So what you did there was you just factored in the tumor and ultrasound characteristics, right? A little bigger nodule. We've published, and other people have published, you can actually watch nodules up to 1.5 centimeters. But fortunately, as I understand it, papillary cancer doesn't understand the metric system, so it doesn't know that it's 1 centimeter. So there's really a biologic range there. So we can watch those up to 1 centimeter. But in young people, they're more likely to grow. 10 to 20% of these grow if I try to watch a 20-year-old. Maybe 4 or 5% grow if I try to watch an 80-year-old, so that'll be part of it. Pregnancy could have some mild effect on the thyroid cancer. Now, I've had about 10 or 15 patients get pregnant while we were watching, just to make my hair get more gray and make sure I still take my Pepcid and that sort of stuff. And 9 out of 10 did fine. We didn't see any change. One of them, hers got bigger after pregnancy, but I'd been following her for about 5 years before she got pregnant. Her curve was showing it was already growing before she got pregnant, and then she got pregnant, and guess what happened? It was exactly the same size we would have predicted after pregnancy. So some of the data that we interpret that thyroid cancer made something grow may or may true and unrelated, right? Now, but there are some cases we've seen that truly grow. So in her case, she actually chose to do a lobectomy, which I thought was the right thing to do. Let's take it up one more notch. This one's 47-year-old, asymptomatic nodule while shaving. This is a 2.5 centimeter. Like most men, we assume if we ignore a 2.5 centimeter lump in our body for long enough, it will go away. Yeah, and all the guys are like, yes, and more importantly, all the ladies are going, yeah, that's what you morons do. That's good. 2.5 centimeter, highly suspicious nodule. No other nodules, no other lymph nodes. Biopsy's papillary cancer. He has totally rejected shared decision making. It's all your decision, so don't give me that shared decision making stuff. The best time it happened to me, it was with a straight face. He goes, I'm paying you a lot of money. What do you think I should do? And I'm like, well, that's totally fair. That's good. So that's the situation. 47, 2.5 centimeter. On this one, watch, lobe, or total thyroidectomy. Watch, getting a little big for watching. Lobectomy? Total? Yeah, we're about split down the middle, right? Now, if we'd have done this 10 years ago, there'd be a very few people in the room that do lobectomy, right, at 2.5 centimeters. Big centers like your guys and us would do it selectively, but outside of that, that would have been completely total. And what you're in that risk stratification of this initial therapy. And you have to go through the discussion with him, well, what if we find something intraoperatively that's unexpected? And as you start doing lobectomies on 2 and 3 and 4 centimeter nodules, the likelihood of finding things a little bit more unexpected goes up a little bit. You hardly ever find that in a 1 centimeter, but as they get bigger, sometimes they'll find lymph nodes, or sometimes you'll find it stuck to the strap muscle or stuck to the trachea that we don't really anticipate. Nothing terrible, but enough that you'd say, boy, I wish I'd have known that before surgery. So they have to understand that. And at 2.5 centimeters, we're getting into that point where maybe the tall cell variants make a difference, and maybe the vascular invasion makes a difference when you get in this 2 and 2.5 centimeter range, right? So the likelihood of having to make a decision about going back for more surgery gets more as the tumor gets bigger. But I told him I thought lobectomy or total thyroidectomy, both reasonable options. It makes a difference where they do their follow-up. We've been doing lobectomies forever at Memorial. I'm completely comfortable doing follow-up with lobectomies. I know how to do that. That's what I do. But some of these patients are going back to other countries. They're going back to other parts of the states where the follow-up is really dependent on total thyroidectomy and thyroglobulin. You have to factor that in, right? So the exact same tumor, because those patient follow-ups and factors, and what do they value? Some people value, I want you to minimize my risk of recurrence. I don't ever want another surgery. Put me to sleep one time. I don't want to have to worry about cancer on the other side, right? All of those are reasons that don't really have to do with our oncology, but have to do on patients' values and preferences within reason. And so in his particular case, he really did make me the decision. And so Ashok Shah did a lobectomy on him because we're big fans of lobectomy, and he lives about 3 blocks from the hospital. What about this one? Let's take it up one more. So now this is a 52-year-old. You've actually done the total thyroidectomy at this point. Everything was fine. The surgeon thought it was a cool operation. They did the usual, go to the waiting room. I did a great job. It's going to be beautiful. It wasn't stuck to anything. You're going to do lovely. Come back and see me in a week. I did a great job. The scar looks great. Everything is fine. And then the path report comes in. There's some minor extrathyroid extension, not seen intraoperatively, but right at the edge of the capsule. 2 little small lymph nodes came out with the thyroid. This idea of lymph nodes coming out with a thyroid is so common, it is part of our pre-op discussion with a lobectomy. That if we do a lobectomy, every once in a while we're going to find some little teeny tiny microscopic lymph nodes that the surgeon can't see. We might find some little microscopic extrathyroid extension. That's not going to change my recommendation for a lobectomy, so that they know that ahead of time. So we'll build that into our thing. So you've got both of those. No other worrisome features. It's just papillary. And 6 weeks after surgery, the thyroglobulin is less than 0.2 with no antibodies. So in our spectrum here, you were after surgery. You know the path report. You've got an early response to therapy, right? That thyroglobulin, it'd be easy if the thyroglobulin was 100 6 weeks after surgery or 500, right? So now you got a thyroglobulin that's very reassuring. Does that mean he can't have thyroid cancer? No. Could. Right? We've already told you the truth about the antibodies. I hate when that happens. When you show the Giovanella paper and go, if you really want to know if somebody's negative in antibody, you have to do 4 different assays. That just hurts your heart, right? Don't do that. We've been lying to you for all these years. If it's negative in one assay, we pretend like that's okay, and that's worked for us. But that's where we are. That was your talk, Jessica, right? Did I translate that? No, don't do that. So here's your question. So you've done the total thyroidectomy, and now the question is, are we just going to follow? You're going to put him on TSH suppression, which would be a TSH below the normal range. Let his TSH be maybe 1 to 2, no suppression. Do a radioactive iodine scan. Treat with 30 or treat with 100. So 52-year-old, total thyroidectomy, minor extrathyroid extension. Everything was going cool till you got the path report. And now you're sitting in the room with him with the path report making this decision. So how many would say his TSH is, I don't know, make it 2 or something like that? His TSH is 2. How many say, fine, don't do anything else, no thyroid hormone? Cool. How many people say, well, I don't want to do anything else, but I'd be happier if the TSH was maybe 0.5? So a little TSH suppression? Okay, cool. How many say do a radioactive iodine scan, see what's going on? Not much there. How many say 30? 30 millicuries? Not a bad idea. And how many say 100 millicuries? Perfect. And how many are tired of this game? Okay, cool. Yeah, cool. So what do you really do? So how many say radioactive iodine yes or no? Radioactive iodine yes? Radioactive iodine no? Radioactive iodine, I really don't want to give it, but I'm a little uncomfortable to make that decision? Yeah, that's where we're moving, right? So this idea that these risk factors, this clearly puts him kind of intermediate risk, right? So in that ballpark, so what I told him, we're in that risk stratification. We know the AJC, we know the ATA, we've got the thyroid globulin. We've already had an early response to therapy. We don't think we're missing widespread distant metastasis. So then the decision becomes, you might have microscopic disease in the neck. In oncology, this is a true adjuvant therapy discussion, right? If you have, in the true sense of adjuvant therapy, you had breast cancer, they took everything out, and they say, you might be cured, but you should probably take some chemotherapy because in 1,000 people, it'll decrease your recurrence. So in this adjuvant therapy, you're treating a risk. She might or might not need radioactive iodine. You don't know that. But is the benefit of doing that to lower the potential risk worth it? So think about that in the true adjuvant therapy, you're treating a risk sort of situation. And in her particular case, what I told her is I don't think radioactive iodine is going to make you live 1 day longer. I tell them I think her survival is 100%, comma, there are too many lawyers in the United States, so my note will say greater than 99%. And they all laugh about that, and they call me back and go, you really wrote that. And yeah, I did. Radioactive iodine might have a mild impact on recurrence, but I think her risk of recurrence is really low right now. Minor risk factors from the path report, good surgery, post-op thyroid globulin looks great. You can do an ultrasound if you want to. I'd bet her risk of recurrence is 2 or 3%. And she may be happy with 2 or 3%. Even if you invoke the Mazzaferri data, the risk of recurrence drops by 50%. So 2 to 3% versus 1 to 2%, right? So probably not a huge impact on recurrence. It's also important to let them know if you need that for follow-up. I think in some of these patients, we've given up on diagnostic scans too soon. There could be a role for a tracer diagnostic scan here. Yeah, we'll see the thyroid bed, but maybe her question was, do I have other RAB lymph node mets or distant mets? Unlikely with a TG that's low, but maybe a TG01. So this idea that you have to give radioactive iodine, we're starting to come back and revisit in certain situations, would a diagnostic scan be useful to us? I wouldn't fault anybody for giving her 100 millicuries because I think still in the ATA 2015 with some small lymph nodes and some minor extrathyroid extension, but I personally think that's way over treatment. And in our setting, if she wanted radioactive iodine, we would give her 30. 30 is the dose we use for people that don't need radioactive iodine. But it'll help you with staging. It makes them feel better. You hardly ever cause side effects with 30. You get good additional staging. It makes the thyroid globulin low, so it's not too bad. All right, here we go. 33-year-old. Now let's do some follow-up stuff. So this is a 33-year-old female. 2 years ago, so we're now 2 years down the road, she'd had total thyroidectomy and radioactive iodine. I showed this online the other day, and somebody wrote and said, why did you give her 100 millicuries? Remember, when bad things happen and you're giving the lecture, it's always an outside hospital. You guys are the Cleveland Clinic. You know that, right? So when you make your slides, just always an outside pathologist, outside hospital. When we screw up, we don't tell people, but we'll find your cases and put them on here and Sipperstein in the bottom corner. So total thyroidectomy, or radioactive iodine, got 100 millicuries of radioactive iodine. The path report was 2.3 centimeter papillary, 2 out of 10 lymph nodes, probably had a little central neck lymph node dissection, and had just a couple of small focus of papillary cancer. So in what I showed you before, somebody I probably wouldn't have given that radioactive iodine. But now we're 2 years down the road. She'd had an excellent response to therapy this entire 2 years. Thyroid globulin has been undetectable, Antibodies are undetectable. Her neck ultrasound at 2 years was unremarkable. I don't suppress these guys' TSH. I let them live in that sort of 1 to 3 range. If there's one thing I wish I could go back and change in the 2015 guidelines, as we said, after lobectomy, the TSH should be less than 2.5. Good luck looking for the reference for that. Sherman and I totally made that up. If I'd do it again, I'd make that number 3, because apparently every patient I do with a lobectomy has a TSH of 2.6. There's nothing magic about that, but we just wanted to say you don't have to put them all on it in that ballpark. So here's your case. 2 years down the road, excellent response. So she would have been technically sort of low to intermediate, right? That's how she was born. Born low to intermediate. Born stage 1. Excellent response. You can't get any better than that. I'm going to ask you 2 questions. Let's talk about her thyroid hormone dose. So would you increase the dose, continue the dose, or lower the dose? Increase the dose, quickly. Increase the dose. Letter B. Cool, there we go. All right, that's good. And then what about this? Now we're 2 years down the road. We know a lot of information at 2 years. Now what are you going to tell her? Come back to see me in a year with lab testing. And do we have fellows here? Fellows here? Good, good. Okay, cool. The physical exam, you familiar with that? It's still technically possible. Just imagine, it happened to us once. There was a blackout in the city. We couldn't get the ultrasounds to come on. We still used our hands, and everybody's still alive. That was like 20 years ago. So come back for blood testing and a neck exam. Come back with blood testing and ultrasound. Come back with blood testing, ultrasound, and a neck CT. So how many people say, come back and just let me feel the neck? Cool, fine, yeah. If you're like me begging them not to do a telemedicine, come in every once in a while. Come back and do the blood testing and the ultrasound. Option number 2, cool. And come back and do more, ultrasound and neck CT. Probably not. So we're in that ballpark there. Now, when you look at where we are, you have to sort of think pretest probability. Low to intermediate risk. If you do nothing, what's the likelihood of her dying from thyroid cancer? As close to 0 as you can get it, right? What's her risk of recurrence at this point? She was kind of lowish to begin with. She's had an excellent response. We've used the best freaking tools on the planet with a thyroid globulin that's so low and an ultrasound that shows nothing. If you had to guess, what do you think her risk of recurrence is? 1%? 2%? Scattered over the next 5, 10, 15, 20 years. So that's where you're starting right now, 2 years down the road. An ultrasound, likely to find disease? No. Likely to find an atypical lymph node you don't want to know about? Likely to find an inflammatory node? Remember how we all quit doing these during COVID and nobody died? Because all we were getting was false positives, right? If you look in this setting, the likelihood of finding real disease on the ultrasound is far more to get false positives. We have got to get out of the ultrasound business in these patients. That we are just using a test. I told him yesterday, it's a little like if you do a pregnancy test on me and it comes back positive, either there's a lot about me you don't know, or 2, you used a really good test in the wrong setting, right? You instantly knew that was a false positive for me. And in this setting, the vast majority of stuff that we see on the ultrasound is a false positive. Now, the guidelines are going to back off on the ultrasound. I doubt that they're brave enough to say never do another one. But if they'll even make the step to say do another one in 5 years or do another one in 10 years, where it's reasonable to find that 1%. If it's thyroid cancer, maybe it's a 1 centimeter lymph node 5 years down the road and we can treat it. The criticism always becomes is you don't know what's going to happen if you don't do ultrasounds. And I always counter with, yes, we do. It was called 1970, 1980, 1990, 2000, 2010. Alan and I and Manjula were treating these patients with our hands. We had 100% survival. They weren't dying. And that idea that minimal disease detection made a huge improvement, not so much. So I think looking at that and being willing to back off. The other thing that I've found out over the last 10 years, it's a lot more easy for me to talk you guys into doing something extra as opposed to doing something less. I can show you 2 or 3 slides and you go, yeah, I'll do more of that. Yeah. In the 2006 guidelines, we wrote, consider prophylactic neck dissection. You know what the word consider to me meant? Think about it and don't do it. That's when I consider something. Like my kids ask me to do something, and I'll say, I'll consider it. And what do they know? That's a delayed no. I'm going to say no, but I want to be a good partner. I want to be a good dad and granddad. I'll think about it. So we use that word. And what happened? Now people started doing central neck dissections. But when you try to roll things back, it's much more challenging. So in her particular case, what I said, you don't need more suppression, keep the thyroid normal. We do the thyroid globulin blood test every 2 years because in our current EMR, the farthest I can put your visit out is 2 years. So there you go. You got a 2-year visit. But we're getting Epic, so I don't know if that'll change. So when we get Epic in February, we'll see how far I can push people out. But the guidelines went to every 2 years. And to get out of routine surveillance for the ultrasound. Feel the hands with your neck. Have the primary care doctors feel the hands with the neck. You're looking for a golf ball in the neck to make some treatments. Do the thyroid globulin antibodies occasionally over time. These do not have to stay in the centers of excellence. They can go back to community endocrinologists with what we call a passport. If you have leukemia, you're going back to the community oncologist after 5 years. Breast cancers are going back after 5 years. Prostate, 5 or 10 years. We call it a passport that tells the primary care doctors what to do and not do, or the primary endocrinologist what to do and not do. So her passport would say, do thyroid globulin antibodies every 2 years, keep the TSH between 1 and 3 to make something make up. And then there's a list of do not do. Do not do an ultrasound. Do not do a radioactive iodine scan. Do not do a CT scan as routine screening, right? Because otherwise you send them to the community and the first thing that happens is they get an ultrasound and they're back to see you in a year anyway. And then we go, well, I'm not going to do that anymore. I just made a new patient for myself. So there's some techniques for that. All right, let's take it up one more time. So this one is a 22-year-old female, total thyroidectomy. Joyce, what time am I supposed to quit?
Whenever you want.
No, don't say that. What time is it?
12.
Oh, cool. We're in good shape. 22-year-old, so 2 years ago, total thyroidectomy, central and right lateral neck dissection. So we're already thinking about somebody that's up on that intermediate or possibly high risk, right, depending on the size of the lymph nodes. She got a dose of radioactive iodine, larger tumor, 4.6, 18 out of 27 sampled lymph nodes had papillary thyroid cancer. The largest node was about 3.4 centimeters. So in the HA risk stratification, that makes her high risk of recurrence, right? The percentage of lymph nodes matter, the size of the lymph nodes matter. These patients, when we see them on day one, it's unlikely they're going to get an excellent response. They get biochemicals or indeterminates or little small lymph nodes. I routinely tell these patients, I love my surgeons, but surgeons are good, but they're not God. They can't take out, if they took out 18 lymph nodes, number 19 might still be living in there, and we're just going to recognize that as persistent, and we'll find it. Over the last 2 years, the TSH has stayed in that 0.5, because I was worried about her. She was a biochemical incomplete, and that thyroid globulin is just slowly marked up, 3, 4, 5. Now we're up to about 9. And now, 2 years down the road, the ultrasound finally finds, a year ago, it was kind of an atypical 1 centimeter lymph node that wasn't really thyroid cancer, but wasn't really normal. We kept an eye on it. And this year now, it's highly suspicious. It's got a cystic change, and the biopsy's papillary cancer. And so now the question's for her. So we're 2 years down the road. She started with a bunch of lymph nodes. She was a biochemical incomplete for almost 2 years. Now she's a structural incomplete because we found her disease. And the question here, just keep watching. Do additional cross-sectional imaging of CTs or MRIs. Go ahead and treat with radioactive iodine again. Do surgery just to pluck out that lymph node. Or do surgery to remove the node and some other surrounding nodes. Right? This is the board exam. What's the next best step? A lot of these things are reasonable, right? What's the next best step? How many say next best step? Keep watching. Yeah, even me, I got to admit, somebody needs to be treated every once in a while. More cross-sectional imaging is the next step. Cool, that's a few. All right. Radioactive iodine. Awesome. It worked so well the last time. Let's do that again. Good. Surgery to take out just the metastatic node. And surgery to take out the node and lots of stuff around it. Kind of in that ballpark. Yeah. So when you look at this case, you have to sort of say, what's the goals of surgery? I think one of the things that we get trapped into as endocrinologists is we do everything off the ultrasound. And in one like this that had a bunch of lymph nodes to begin with, part of her follow-up, I would have actually done a CT scan of the neck a year down the road, looking for lymph nodes outside the field of view of the ultrasound. And over, where do I find them? Retropharyngeal lymph nodes, way out laterally, upper mediastinum. So in a biochemical incomplete, I'd be thinking, yeah, maybe we got it all, but those lymph node chains don't have a dam. They just keep going, and where did we find them? And so we found them. So I think the next step in one like this is depending on which one of my surgeons, most of my surgeons operate off CT of the neck with contrast. We would do a CT scan of the neck and chest, looking to see, yeah, we're going to have to do a surgery, but I just want to do this one more time, get a good mapping. I know the iodine will delay my radioactive iodine for a while, don't care. What I care about is surgery. Some of my younger surgeons trained with MRIs. They're very comfortable operating off MRIs. So you have to talk with your surgeon and say, what do you use? What is your cross-sectional imaging? But over and over, I see patients like this get sent back, have this lymph node taken out, the TG drops from 9 to 7, and then you find the disease. Yep. Yeah, use the microphone now. Yeah, that's a great question. So the question is, in the past, we would have often just done a radioactive iodine scan with thyrogen, and done part of that. If I tell you what I really do in a situation like this, I actually do, before we go to surgery, I actually do a thyrogen radioactive iodine scan to see if this lymph node is RAI avid. Because I know after surgery, I'm going to have that discussion about whether radioactive iodine would be useful. So if we're doing thyroid cancer 600 level, so what I'd really do is I would do a thyrogen scan to see if that lymph node was RAI avid or she had RAI avid disease anywhere else. In this setting, they're almost always negative, but then that takes radioactive iodine off the thing. And then we would do a CT scan of the neck and chest with contrast, and it's all set. So I think in the setting of macroscopic disease, it's very helpful to know if that tumor would grab onto radioactive iodine. I tell them it doesn't get you out of surgery. I can't kill a 1.5 centimeter lymph node with radioactive iodine. But if that was RAI avid, then it would make sense to me to do another dose of radioactive iodine. You seldom see it in that sort of ballpark.
Does molecular testing of the FNA specimen make a difference?
Yeah, that's a great question. As a general rule, no. So we typically don't do molecular testing of the lymph nodes and that sort of stuff. I hope that answer changes in 5 or 10 years. Because it would be really nice to have the molecular testing to tell me, is it likely to be RA avid or not? There's a few things we know right now. It helps me slide the likelihood. So I'm hoping the answer is yes in 5 or 10 years, that we can use that as predictors, both prognosis and that sort of thing. So in this case, yep, Terry. That's a great question. So the question for the online group is, if you have a papillary microcarcinoma, these small things that you're going to watch, we recognize that some of them grow, and it's like 10 or 20% grow. It's not a small number. Could you do molecular testing to predict which ones were likely to grow? And right now the answer is no. And the reason the answer is no is that most of those ones that had the molecular testing that looked more aggressive, they are not 5 millimeters confined to the thyroid. They already have lymph node metastasis. They have some extra thyroid extension. They have other markers that even at 5 millimeters takes you out of the watching program. So the ones that were going to be really bad that next year or 2 or 3, they're already out of the program. The ones that are going to slowly change over 5 years, you can't tell. Because I think in those guys, even if you had molecular testing, they could still have a subclone that had the BAT gene and you just didn't pick it up. And so you pick those up because they start to change over a year or 2. So the goal of active surveillance is not to identify people that never change. It's to identify the large group that are stable, and more importantly, identify the ones that are changing at a time point where delayed therapy intervened before the bad stuff happened, before they turned into poorly differentiated anaplastic, which is where we would go. So I'm going to stop there and say what I hope I showed you was to give you some idea about sort of how the guidelines are likely to change coming up. From what I've seen, it's very consistent with what we're talking about here. This goal toward understanding what the patient goals are, being patient-centric with the patients, doesn't mean you get to unload and the decision is all theirs. You got to be part of it. But having that as an important piece to what's the values, what's the goal, what are they aiming for, and then tailoring your treatments within that range of acceptable. We can't do what's wrong or over or underactive, but within that range of what may work, even if I'm not personally wouldn't be my first choice, if it's within the range that could work, using that risk stratification to help you frame that together. Thanks very much.